بسم الله الرحمن الرحيم الحمد لله رب العالمين وصلى الله وسلم وبارك على نبينا محمد. Greeting to you all. Today inshallah ta'ala I will be talking about pathophysiology of cyanotic congenital heart disease. I am Dr. Jamil Abdulaziz Atha. I'm a consultant pediatric cardiologist at King Abdulaziz University Hospital, Jeddah, Saudi Arabia. So to start with, what is cyanosis? Cyanosis is basically the blue discoloration we see on patients. So cyanosis is being blue. And why would we become blue? It's mainly because our hemoglobin, which carries our oxygen, becomes deoxygenated. So we call it deoxyhemoglobin. And if we carry too much deoxyhemoglobin in our blood, we will become cyanotic. From cardiac point of view, cyanosis comes from two major issues or two major problems that happens to the child or to the infant, and then he or she would get cyanotic. So the first thing is the major cause of cyanosis, which is the right to left shunt. Any blood from the right side of the heart is a blood which is deoxygenated. We know the right side of the heart is composed of the right atrium and the right ventricle, and both receive the blood from the inferior vena cava and the superior vena cava. And I will draw that when I come to specific lesions when I talk about them. Any blood going from the right side to the left side, which is supposed to be receiving the oxygenated blood from the lung, which is the left atrium and the left ventricle, that will cause the blood on the left side to be mixed with the deoxygenated blood, and hence the patient will become cyanotic. So mixing, or right to left mixing, is a major or the major cause of cyanosis from cardiac lesions. In addition to that, if one would become more cyanotic, if this right to left lesion is added to by decreased pulmonary blood flow. If we have decreased pulmonary blood flow, that means the lungs are not receiving the full cardiac output they should receive, then that would also lead to less oxygenated blood coming to the left side, adding to the problem and making the person more cyanotic. So this is the basics of being cyanotic. So how much hemoglobin do we need to become cyanotic? Obviously, if you are too much anemic, let's say if a baby has a hemoglobin of 7 grams per deciliter, then this baby, because of severe anemia, severe pallor, may not show the cyanosis well. We know that for us to show cyanosis, we need at least 5 grams of hemoglobin to become deoxyhemoglobin. Imagine somebody with a hemoglobin of 7, how he or she could have 5 out of 7 and living only on 2, that will not be livable. So these babies will not show cyanosis because of severe pallor. And that's an important caveat in clinical examination of babies with cyanosis. We human beings can detect somebody with cyanosis, calling them blue, if what we call the oxygen saturation by pulse oximetry, and pulse oximetry is a methodology by which we measure oxygen saturation, which is widely known today, and actually it should be and is part of the vital signs of any patient coming to a medical facility. So for cyanosis, for us to catch it by the eye, the person has to be at least 85 or above, below 85, we can detect cyanosis. So if a person comes, the normal saturation for us is 95 to 100%. We call it the SpO2. Okay, so that's your normal saturation. When can we detect cyanosis clinically? Before anything else, before any investigations, if the person is 92, our eyes cannot detect it. 90 cannot detect it. We start detecting cyanosis by our eyes when the person has a saturation of 85%, which tells you how far it is from 100 to 85. 15% less, then we start clinically diagnosing it, which means clearly we can miss many cyanotic children, many cyanotic infants, many cyanotic persons who come to our clinic if we do not do pulse oximetry. Obviously, the cardiologist trained eye may pick up cyanosis at slightly higher than 85, maybe 88, 90, but definitely we are all going to be deceived if the saturation is 92. And we have to know that even a saturation of 94, which is very close to 95%, is not a normal saturation. We still call that person a cyanotic child or a cyanotic person. So when we talk about cyanotic congenital heart disease, there are many classifications for such disease. And just before that, I would just want to add that cyanosis can come from non-cardiac reasons, as we all know. If we have severe lung disease, if we have methemoglobinemia, and other causes. But here today, our talk is really concentrated on cyanotic congenital heart disease. We can divide cyanotic congenital heart disease into many classifications. One of the best is to divide it based on amount of pulmonary blood flow. So if we say cyanotic congenital heart disease, CCHD, cyanotic congenital heart disease, one of the best ways of dividing this disease is actually to talk about, is this cyanotic congenital heart disease with increased pulmonary blood flow, or is it with decreased pulmonary blood flow? Such a classification is quite good in making us understand such a disease. And we have common diseases that fall under increased pulmonary blood flow, and they are cyanotic. And we have also other common diseases with decreased pulmonary blood flow that have or that fall under cyanotic congenital heart disease. And by the way, there are ones who do not fall under any of them, but they share the same origin, which is cyanotic heart disease. What can we think of? Common diseases in each arm. In increased pulmonary blood flow, what can you think with me? Who has a right to left shunt but do not look that much blue because they have a lot of pulmonary blood flow? And this is one difference between the two groups, that with increased pulmonary blood flow, that's SpO2 tends to be higher. Higher meaning it's anything between 88 to 94%. And when we talk about decreased pulmonary blood flow, usually the saturation there is less than 88%. Sometimes even much less than that. One important factor that differentiate both or is common in one and not common in the other one, usually in patients with increased pulmonary blood flow, there is no pulmonary flow restriction. or what we can translate into there is no pulmonary valve stenosis. So here there is no PS, while on the other side there is usually valvar pulmonary stenosis, or PS as we would abbreviate in our talk. طيب, so let me just write down for you some of the common, and then we will go into how we describe them and how we talk about them. So with increased pulmonary blood flow, there is one famous lesion which we call total anomalous pulmonary venous connection or drainage. This is one common disease that falls under the increased pulmonary blood flow, and so many other diseases. And on the other side, there is tetralogy of Fallot, or TOF. I hope the color is clear and you could see it. The green did not really show the best. So I will be spending more time now on talking about total anomalous pulmonary venous drainage as an example for cyanotic heart disease with increased pulmonary blood flow, and on tetralogy of Fallot as an example of decreased pulmonary blood flow in cyanotic congenital heart disease. So just to recap, we are talking today about cyanotic congenital heart disease pathophysiology. I'm not talking about the disease clinically in depth, but I'm really talking about the pathophysiology. And as we understand pathophysiology quite well, we can definitely treat and understand the disease much better than if we don't. So let's take our first example, which was total anomalous pulmonary venous drainage, as an example of cyanotic congenital heart disease with, can I hear it from you? I know you're not there, but I'm going to say it, with increased pulmonary blood flow. We have agreed that we will be talking about total anomalous pulmonary venous drainage. So I will just remind you quickly about the anatomy of the heart. So if we draw a normal heart would look like this: two ventricles, two atria, and then the muscle, the interventricular septum, the other muscle, and these are the atria which are divided by the interatrial septum. This is the left ventricle, and this is the right ventricle. This is the left atrium, and this is the right atrium. Obviously, there's a valve which is called the tricuspid between the right atrium and the right ventricle, and the mitral valve is between the left atrium and the left ventricle. Since we are talking about total anomalous pulmonary venous drainage, we are interested in the veins that normally come to the left atrium. We have 4 pulmonary veins that come to the left or right side of the left atrium, and the other 2 to the left side of the left atrium. And hence, these are the pulmonary veins. These are the left side and these are the right side. They come to the left atrium after being oxygenated from the lung. This is normal. So when we call total anomalous pulmonary venous drainage, that means these whole 4 veins, they are no more coming to the left-sided atrium. Their blood flow is now being delivered to the right side. And since they are veins, they can only go to areas which are venous or low pressure like them. So imagine with me, where can they go? We can have the 4 veins going directly to the left atrium. That's a possibility, although not the most common. Okay, so in total anomalous pulmonary venous drainage, the 4 veins, instead of coming to the left atrium, like you can see here, they come to what we call the pulmonary venous confluence, just above and behind the left atrium. So you see the 4 veins, 1, 2, 3, 4, 2 on the left side, 2 on the right side. They join into a confluence. They do not have a connection to the left atrium. And then with a vertical vein, which is a remnant from the embryological venous formation, they join the innominate vein, and then they pour all this pulmonary venous return from the lungs to the SVC and back to the right atrium. So let's follow the circuit. Now we have blood coming from the body to the right ventricle, being pumped to the pulmonary artery, to the lungs, obviously, and then coming back from the lungs to the pulmonary veins. But instead of going to the left side, this blood will now go back to the right side through this channel. So the blood flow basically is body to right ventricle to the lung and back to the right ventricle. So the blood is actually trapped there. If this is true, then we cannot live, because all the cardiac output is just sitting in the right side. Obviously, Allah subhanahu wa ta'ala, with all his mercy, these patients live, they don't die. Why? Because they have what we call an obligatory atrial septal defect. So you see the interatrial septum here in a normal person would be intact, no holes, no gaps. But in a total anomalous, there is almost always a huge defect here. We call an atrial septal defect with different types, but it's a must. Why is it a must? Because the red blood coming from the lung, now instead of going to the left side, it will be going through here, the vertical vein, innominate vein, SVC, and into the right atrium. It has 2 ways to go, either through the tricuspid valve to the right ventricle and then to the pulmonary artery, but also it can go through here, the ASD, to the mitral, to the left atrium, to the mitral, to the LV, to maintain the cardiac output through the LV and the aorta and supply the body. Obviously, the blood would like to take the least resistant area, or the pathway where it is more compliant, less resistant, lower pressure, which is, as we all know, the right ventricle. So more of the blood will go to the right side and less will go. In spite of that, the patient can maintain the cardiac output, but obviously with tremendous increased pulmonary blood flow. And that's why these patients may present eventually with either heart failure symptoms or severe significant pulmonary hypertension or right ventricular failure if not treated for a long time. One important pathophysiological point in such a disease, you could see that all the blood, that means all the cardiac output, the venous cardiac output, is actually coming to one chamber. So blood that is coming from the IVC, the SVC, the pulmonary veins, they are all pouring into this chamber, which is the right atrium. And hence they are all in and in one chamber. This provides what we call complete mixing or excellent mixing. What does that translate to? That's another pathophysiological important issue to understand, that when you have complete mixing, you rarely have severe cyanosis. And that's another factor making total anomalous saturations between 88 to 94%. Not only there is increased pulmonary blood flow, but there is also complete mixing, and that diminutes or decreases the amount of cyanosis. So this is an example of such a disease. Now let's follow the pathophysiology. What's going to happen when such disease occurs? You will find that there is complete mixing. The left side may have or will have less flow, and hence the left side actually may become smaller to the extent it may become even hypoplastic, but that's quite rare. Most of the time it's still good in size enough to carry up the systemic cardiac output, but it can be smaller because of less flow. Obviously the right side will be dilated, so the right atrium will be significantly dilated. It's the one receiving all the venous, pulmonary and systemic blood amount. The right ventricle will also be significantly dilated because, again, most of the blood will go through the right side or the right ventricle because of low pressure, low resistance in the lung, and compliance of the right ventricle. So the right side will be quite significantly dilated. Pulmonary pressure, if left untreated for a long time, may become high with a mean of more than 25 millimeter mercury. And when we say left untreated for a long time, we're talking about anything between 6 weeks to 4 months. That's the area where these patients have to be catched early and undergone surgery to correct such an anomaly, to prevent such an abnormal pathophysiology. Obviously, if left untreated, pulmonary hypertension can happen, cardiac arrhythmia can happen, heart failure before that, many abnormal pathophysiologies. But let's concentrate on the disease itself and what we have done. I'm going to recap. The disease is basically the 4 veins. When we say total anomalous, the 4 veins are anomalously draining or connecting to the right side of the heart, and one of the most common ways is to connect to the innominate vein. Actually, this vertical may go downward and connect to the hepatic, to the IVC, through the hepatic portion of the IVC, and then usually it's obstructed, or it may go directly to the right atrium. We call this supracardiac. The one to the hepatic portion of the IVC, we call it infracardiac, and the one that goes directly to the right atrium, we call it cardiac type. Okay, so we just have finished the cyanotic congenital heart disease with increased pulmonary blood flow. The session now is to complete the other arm and giving another example of cyanotic congenital heart disease with decreased pulmonary blood flow. So the lungs are not receiving the same amount of cardiac output like the left side. There is a difference. It's not like one cardiac output to the right side and one cardiac output to the left side. It could be less than 1 to the right side and more than 1 to the left side. Just to refresh, this is the normal anatomy again. So we have the right side completely separated from the left side. The right side receives the inferior vena cava blood, which is the deoxygenated blood, the superior vena cava blood, and then goes to the lungs to be oxygenated, only to return back through the pulmonary veins, 2 on the left side and 2 on the right side, to supply the left atrium, the left ventricle, and the aorta, and so on. And by this, we maintain our saturation normal on the left side, and we take the deoxygenated on the right side to send to the lungs to be, or to pump to the lungs to be oxygenated. So let's go through this anatomy of tetralogy of Fallot, and then go about the pathophysiology that we expect from such flow and such anatomy. So we all know that tetralogy of Fallot is comprised of 4 cardinal lesions or criteria. There is a VSD, so an the interventricular septum is not complete. It has a defect, and it's a subarterial defect just below the aorta usually. So we call it a large subarterial or subaortic VSD. That's component number one. The other important component that tetralogy of Fallot have, and it has a lot of implications in the pathophysiology, is pulmonary valve stenosis and subpulmonary valve stenosis. That means stenosis or narrowing below the pulmonary valve because of muscle, and at the pulmonary valve itself because of valve abnormality. And you could see not only that, but also the pulmonary tree itself is much smaller compared to the normal. This is the pulmonary valve. It's almost equal to the aortic valve. Look at here how the pulmonary valve is much smaller and the aortic valve is actually larger because it is carrying more cardiac output. Look at here, the sub area is clean. There is no muscle. And look at here, we have this big chunk of muscle narrowing the entrance to the pulmonary valve. So this is number 2 criteria in tetralogy of Fallot. Number 3, the aorta itself is slightly deviated to the right. It has moved slightly to the right. You can see here the aorta compared to the interventricular septum, it's to the left of it. But here in tetralogy, it's actually sitting on it. You see, it is sitting on it, or it is overriding it, okay? Imagine this is a saddle and this is the back. It's overriding the septum. And this is criteria number 3. Criteria number 4, there is significant right ventricular muscle hypertrophy. Look how thin the right ventricular wall here is, quite thin. And look how thick I have drawn the right ventricle. All these 4 have pathophysiological implications in such a disease. So let's talk about now pathophysiology. And the only way to talk about pathophysiology is really to follow the blood and keep in mind where the blood likes to go and where is it going to be directed by the lesion that we have in hand. So let's follow the inferior vena cava pulmonary blood flow, superior vena cava pulmonary blood flow. There's no problem of this blood going to the right atrium, isn't it? There's no hindrance, there's no stenosis. The right atrium is low pressure to a certain extent, so it can receive this blood. Going through the tricuspid valve is also usually not an issue because tricuspid valve abnormalities in tetralogy of Fallot, though can happen, but they are quite rare. And then the blood needs to go back up in systole to be pumped to the great vessels, the pulmonary artery and the aorta. So if you were the blood, where would you like to go? You have 2 ways. You either go through the muscle bundle, the stenotic area, and the stenotic almost closed valve, or you have the wide open hole or defect or VSD, and then to the wide open aorta. Obviously, the blood will go both ways because depending on the resistance it finds, it will choose. And because the hole is there and the aorta is overriding, once the blood goes up, there will be some blood going to the aorta. This is the blue blood, remember, huh? And obviously for us to live, there has to be blood that goes through the pulmonary artery. So the first thing we notice here, there is an obligatory right to left shunt. The blood from the right side is going to the right ventricle and being shunted or deviated or sent through the VSD to the ascending aorta, and that's the obligatory right to left shunt, and that's the reason for being cyanotic. The main reason, as I can remind you, we said before, the main reason is the mixing and the right to left shunt. Even in total amorous, which we spoke about in the previous part, there is right to left shunt across the ASD to fill the blood, but because of excellent mixing, the blood or the cyanotic blood gets diluted with the red blood and cyanosis does not become too much. Here, we do not have an issue of mixing on the right side. Actually, the mixing is happening on the left side. The obligatory right to left shunt goes through the VSD, through the aorta, and then the cardiac output that's coming from the left ventricle would go through the aorta. So the mixing is really happening somewhere in the VSD and in the aorta. But because we have stenosis here, this right to left shunt amount or magnitude can differ a lot. The more stenosis, the more right to left. And the more right to left, we can have more cyanosis. So in tetralogy, cyanosis is not a stable number. It's not a stable figure because depending on how much obstruction we have, we will have more to right to left shunt. But obviously, because the right to left shunt is mixing on the systemic side, it will be much more cyanosis showing. And because there is limited pulmonary blood flow, because of the pulmonary stenosis and the subpulmonary stenosis, we will have more cyanosis. So in tetralogy, we have the two factors working together to make the patient cyanotic, which is the right to left shunt, plus the decreased pulmonary blood flow. And as I said, and I'm going to repeat, if we have minimal obstruction here, these patients may not show the cyanosis early in life, the first few days. But as they grow up and as the muscle becomes more hypertrophied, they will show the cyanosis more because the right to left shunt will become more because the blood will find it much less easier to go through the pulmonary artery. So this is the hallmark of tetralogy of Fallot. The right ventricle is hypertrophied with all the consequences that can happen. So the compliance may decrease, the right ventricle becomes more stiff, may have diastolic dysfunction because of significant hypertrophy, especially if left untreated for a long time, which doesn't happen these days in many parts of the world because cardiac surgery is available, but it still is a problem in places where tetralogy is not treated in the proper age. So the second, as I said, is the hypertrophy, and the pathophysiology here of stenosis may continue to develop into even pulmonary valve atresia. That means really no flow will go there because of the severe stenosis or the critical stenosis and the severe subpulmonary stenosis, and then tetralogy of Fallot will need to have to live, for the baby to live, he or she will need to get another source of pulmonary blood flow, which is not uncommon, that we find what we call the patent ductus arteriosus. I'm just drawing it for the sake of drawing in this side, although it is not. It usually comes from the descent, below the arch and to the MPA down there or near the LPA, just for making it close for the drawing part. The PDA will give the blood back to the pulmonary arteries, increasing the pulmonary blood flow and improving the patient saturation. This is only in times when the pulmonary stenosis is critical in tetralogy of Fallot, or it's actually totally obstructed, totally atretic, and then we will have to have another source. Sometimes the other source in the pathophysiology of tetralogy of Fallot is not a PDA, it's actually what we call multiple aortopulmonary collaterals. That means because of the atresia here, we may find arteries coming either from the neck vessels or from the descending aorta, like this, collateral arteries coming to supply the lungs with blood flow, and this will keep the patient alive. And that's a very rare form, very complicated form of tetralogy of Fallot. To complete tetralogy of Fallot pathophysiology, we said that this area is not only valve obstruction or stenosis. We said that there is actually subpulmonic stenosis. So obviously, because it is muscle and because it is subpulmonic stenosis, then muscles do contract. And the faster the heart rate, the faster or the stronger they contract. And hence, patients with tetralogy of Fallot may develop what we call hypercyanotic spells. Let me just take this part out to be able to write. So tetralogy of Fallot may have what we call a hypercyanotic spell. What is that? What's a hypercyanotic spell? It is a stage where the patient becomes suddenly much more cyanotic than the baseline. And this relates usually to sudden or significant closure of the muscles below. And this comes either mainly from tachycardia. Patient may have pain, may have hunger, crying, many other issues, medications that can increase the heart rate. All of them may add to the pathophysiology of cyanosis in tetralogy of Fallot, making the patient hypercyanotic. And this is a very unique criteria for tetralogy. It can happen in other cyanotic congenital heart disease with the same anatomy, with PS and sub-PS, but it is mainly known for tetralogy of Fallot. And it just needs the stimulus, which is either the pain, the hunger, the dehydration, medication. The heart goes much faster. Once the heart is much faster, this muscle becomes much more cyanotic area. I have a very unusual way of describing it. If this is the muscle I'm holding, and I can have my colleague here to help me. Can you come? I'm just going to show you. If I'm contracting not so fast, he will drop the pen through my hand, and you'll see, drop it, let it fall. Do it again. You see, it falls easy, but if I contract very fast, the pen represents the blood flow. Look at that now. You drop the pen. See, it won't go anywhere. I'm holding it. The muscle is obstructing it. Thank you. So, whatever causes tachycardia in tetralogy of Fallot is a bad thing to have. So, in tetralogies, we like to keep them calm, quiet, in parents' hands, well-fed, not dehydrated, not in pain. All of this is very important to take care of when you are taking care of a patient who has an unrepaired or not surgerized tetralogy of Fallot. That tachycardia increases the obstruction, so less pulmonary blood flow, and as we said, less pulmonary blood flow means less oxygenated blood going to the left atrium, so this cardiac output is less. Plus, not only that, the right to left shunt now is increased because this area now is obstructed, so there is more blue blood and the baby will become severely cyanotic. If we don't reverse that hypercyanotic spell early by calming the baby, by preventing pain, then it may go to a vicious cycle. The patient now becomes cyanotic. Cyanosis means we're not delivering enough oxygen and enough for body metabolism. The body metabolism goes from aerobic to anaerobic. So now you're producing acid. The baby becomes acidotic. And the more acidotic the baby becomes, the baby starts to breathe faster. This is your normal response for acidosis, to clear away CO2 and decrease HCO3. And by doing that, what is the baby doing is the baby is activating the thoracic pump. And what it's meant by the thoracic pump that you are actually increasing the venous return back to the heart. You take a breath, you're actually getting the blood in because you're creating negative pressure inside your lung. And the faster you do that, the more blood coming from the body. So that is more blood, blue blood coming in. It will go to the right ventricle. We know this is now very obstructed. The baby is crying, fast heart rate. So there is now more right to left shunt, and that's how it goes, a vicious cycle. So now the baby is acidotic, breathing faster, becoming even more cyanotic. Now we're in kind of a critical situation to really stop that. That's happening. We could not calm the baby. The pain is continuing. Even the mother handling could not do anything. Now we have to act in a different way to really get the baby calm. One of the ways is actually to decrease the heart rate, either by giving a medication that prevents the pain, like morphine, and then now we're moving into more like resuscitation type, or giving a medication that slows down the heart rate, like a beta blocker, propranolol. And once we slow the heart rate, we can reverse. This position, such pathophysiology or hypercyanotic pathophysiology is quite dangerous, quite serious. It may end up in cardiac arrest because of severe cyanosis and severe acidosis. So it may create an emergency situation for emergency intervention, whether we go in the cath lab and open this area with a balloon or a stent, or send the patient directly as an emergency for surgery, and the surgeon will create a shunt between the aorta. We said this is the PDA. Now the surgeon actually can create his own shunt between one of the arteries from the neck. Usually it is the subclavian artery we take, or the root of the innominate, to the pulmonary artery. And now we have restored the blood going to the pulmonary blood flow, so better oxygenation, less cyanosis, better aerobic metabolism. Now we're starting to reverse the whole thing back. So tetralogy of Fallot, to recap, is an obligatory right to left shunt. And mixing happens in the VSD and in the aorta. There is decreased pulmonary blood flow, so the cyanosis is quite apparent and it's quite significant, unlike the ones with decreased pulmonary blood flow. There is significant right ventricular hypertrophy, which may affect ventricular, mainly diastolic and compliance function, and this is quite important for post-op surgical outcomes. And we have the unique part of tetralogy of Fallot, which is hypercyanosis because of dynamic subpulmonary obstruction. Tetralogy of Fallot can go further to have either critical or even pulmonary valve atresia, and then the patient will be duct-dependent cyanotic congenital heart disease, needing a PDA, needing prostaglandin to be started immediately after birth, or an emergency BT shunt either after birth because of no PDA, or because of hypercyanotic spell, or because of other reasons that cannot repair tetralogy of Fallot. I hope I explained it quite well, and we will go in the next part to cyanosis because of poor mixing. طيب, بسم الله الرحمن الرحيم. So this is our third session to talk about the other unique pathophysiology we see in cyanotic congenital heart disease, which is the poor mixers, and I'll explain by what do I mean by poor mixers or poor mixing. So it is cyanotic congenital heart disease. We have said before that to be cyanotic, you have to have a right to left shunt. You may be more cyanotic because of decreased pulmonary blood flow, or less cyanotic because of increased pulmonary blood flow. But there is another reason that has nothing to do with right to left or decreased pulmonary blood flow that can make us cyanotic, which is not quite common, alhamdulillah. It is the poor mixers. Let's follow, again, just to refresh, our normal pulmonary, circulation, which we call circulation in succession. You know the 400-meter contest where they pass the baton, as they say. So it's somebody who runs for a distance and then gives it to the other and gives it to the other until they reach the end of the track. And that's how the body is. We send the blood from one area to another, passing all the areas and then coming back to where we came from. No shortcuts in between and nothing different in between. We call that circulation in succession. It produces a lot of benefit. You know, in the racetrack, they can cover 400 meters easily by 4 people, while one person may not be able to cover it in the same faster time. So circulation in succession is a gift to have, whether in you or in the racetrack. So let's go and see how is it circulation in succession. If we start by the pulmonary venous blood flow from the inferior vena cava and the superior vena cava, when it reaches the right atrium, it gets directed to the right ventricle, from the right ventricle to the pulmonary artery, from the pulmonary artery to the lungs, to the pulmonary veins, from the pulmonary veins to the left atrium, to the left ventricle, to the aorta, to the descending aorta, back to the body, and then back as a venous return to the IVC and superior vena cava. That's circulation in succession. We can say it: venous return, IVC, SVC, right atrium, right ventricle, lungs, left atrium, left ventricle, body, and then back to the heart. So if we can simplify it more, it's body, heart, lung, heart, body, heart. That's how it is. So let's say it again. It is body, venous return, heart, lungs, heart, body, arterial supply, body, venous return. It is in succession. Nothing in between escapes. There is a condition called transposition of the great arteries, which is shown in this picture. Mind my drawing, it's not the best, but transposition of the great arteries is a unique cyanotic congenital heart disease that has poor mixing. And let me explain why. It is because of circulation in parallel. It is not in succession. Circulation in succession is a circle. From one side, you go through many stations and come back to the same cycle, like here, and so on. But circulation in parallel is actually 2 circuits going on parallel to each other, not crossing each other, not mixing with each other, not talking to each other. And obviously, that's even not a good thing to have. You don't want to be a loner. You don't want to be not communicating or not connecting or not interacting to be a good person. The same goes to pathophysiology of the heart when it is transposition of the great arteries. So let's follow the blood and see what it is. And when we say transposition of the great arteries, we mean the great arteries are transposed. The pulmonary artery, which originates from the right ventricle, in this case, it's originating from the left ventricle. The aorta, which originates from the left ventricle, it is in this case originating from the right ventricle, and so on. So let's see how the blood is going. The IVC, or the inferior vena cava blood, now goes to the superior vena cava blood, to the right atrium, to the right ventricle, and up to the aorta, going to the body, coming back to the right side, and so on. The pulmonary venous blood flow comes from the lungs to the left atrium through the pulmonary veins, to the left ventricle, to the pulmonary artery, i.e. back to the lungs, and going back to the heart, LV, lungs. So you see now, what do we mean by circulation in parallel? Let's say it as words. So, body, venous return, RV, body, body, venous return, RV, body. So it's really body, RV, body, body, RV, body. That's not good. The blue blood, the oxygenated blood, is not taking its normal pathway to go to the lung to get oxygenated. It's just passing in a closed circuit from the body as a venous return to the right ventricle, to the aorta, to the body, and a venous return. So obviously, it is one severe form of cyanosis because the whole blue blood is trapped on the right side, which sends the blood back to the body, to the aorta, not to the lung, and comes back to the same trap. And because there is no connection between the left side, which has the oxygenated, the red blood, and the right side, these patients are extremely poor mixers. There is nothing mixing, and that's why their cyanosis is one of the worst. So can a person like this live? Obviously, it cannot go like that. It will be just a few minutes to a few hours, and the patient will be dead after birth because of such pathophysiology with no mixing at all is not livable. So usually these babies are born with a patent ductus arteriosus, which is open from the aorta to the pulmonary, and that provides a source of mixing. The blood now, the trapped red blood, can now cross and go into the aorta, and hence the patient starts to become less cyanotic or livable. And that's why transposition of the carotid arteries, when they are born, we may not notice the cyanosis immediately because the ductus is usually open and providing the mixing they need to become enough saturated. And that's why it's very important to do pulse oximetry on all newborns. You can miss easily a TGA patient, baby, because of good mixing through a duct, which we know will close with time, and then becomes back to the original pathophysiology, which is poor mixing, but that may be quite late. The baby may have gone home, coming back with severe cyanosis, severe acidosis, and even arresting. Another area where we mix when we are just born in TGA is the patent foramen ovale. We usually have a small hole in the interatrial septum, and that also allows the red blood to cross to the right side, mixing with the blue blood and making the saturation higher in the right atrium, higher in the right ventricle, and obviously higher in the aorta, making it livable. In a few days, maybe a few hours even, this may close and the PDA may close, and then you will see the true pathophysiology of transposition of the carotid arteries, which is extreme cyanosis because of poor mixing. A third type of pathophysiology of cyanosis that we do not see in other diseases. What's unique here is those patients are an emergency immediately after birth. They need a source of mixing to be maintained to live, part of this poor mixing pathophysiology. So these patients will not live well without a ductus. And once we diagnose them with tetralogy with transposition of the carotid arteries, we start them on prostaglandin, PGE, to maintain the patency of the ductus. And usually that's quite enough to provide them with the saturation needed until they get the corrective surgery, which is today an arterial switch operation. The aorta is put back on the pulmonary valve, and the pulmonary artery is put back on the aortic valve, and the coronaries are transferred. So this kind of cyanosis is severe. It needs a mixing site. Sometimes the PDA is not an enough mixing site for transposition of the carotid arteries, and we have to revert to increasing the size of the PFO or patent foramen ovale, making it an ASD rather than just a small hole. And this can be done in the first few hours, first few days of life, interventionally by cardiac catheterization going from the venous side with a catheter and a big balloon here, and this balloon is pulled against the septum, making what we call a balloon atrial septostomy, and that's usually good enough to provide them with a sizable defect that can give them sizable mixing to improve the saturation in the right atrium, right ventricle, and hence in the aorta. And obviously this is all temporary because they will need the surgery for the arterial switch. There are other types of surgeries. Some unique part to this kind of pathophysiology is that the myocardium here is supplied through, obviously, the coronaries, isn't it? The coronaries in this disease are seeing blue blood. So the myocardium immediately after birth is also seeing blue blood. So we do not be surprised if we get myocardial dysfunction or myocardial ischemia causing myocardial dysfunction if the cyanosis gets added. So heart failure, myocardial dysfunction is also a feature of the pathophysiology of this disease if not corrected, and it's even a feature of post-surgical coronary transfer, but that is not part of the usual normal pathophysiology. That's kind of a surgical or post-surgical pathophysiology. The other thing in transposition of the arteries is that they usually have wet lungs or what looks like pulmonary edema. And this is because the cardiac output on the left side is going to the lung and is trapped there, no mixing. Plus, they are receiving from the aorta the intercostal arteries and the bronchial arteries supplying the lungs, and that extra flow also makes them pulmonary venous edema. That's another feature that adds to the pathophysiology of these patients. So if you leave them, they may go into heart failure, more pulmonary edema. They are already cyanosed, now they have pulmonary edema and may have even worse ventilation, oxygenation, and that adds to the problem. Plus, obviously, they can become severely systemically acidotic because of anaerobic metabolism due to severe cyanosis. By this part, we would have completed the three main pathophysiological features we see in cyanotic congenital heart disease. We talked about the ones with increased pulmonary blood flow, with excellent mixing, having acceptable saturations, being more susceptible to heart failure, having usually no limitation to pulmonary blood flow, but they are susceptible to heart failure and pulmonary hypertension because of unlimited pulmonary blood flow. We talked about and we gave the example of total anomalous pulmonary venous drainage in such increased pulmonary blood flow class or classification. The other one, which is the decreased pulmonary blood flow, and we have the example of tetralogy of Fallot, where we have the obligatory right to left shunt across the VSD to the aorta from the right ventricle, and that's totally deoxygenated blood going to the aorta, causing significant cyanosis. That cyanosis may be increased or decreased depending on the other pathophysiological factor, anatomical factor, which is the presence of subpulmonary stenosis and pulmonary stenosis. The severity determines the amount of pulmonary blood flow and the returning oxygenated blood, and also the amount of the right shunt. The more obstruction in the subpulmonary or the pulmonary valve, the less flow, the more right to left shunt, the more cyanosis, and the less obstruction, the more flow, the less right to left shunt, and better saturation. We also talked about the hypercyanotic spell, which is unique to congenital heart disease like tetralogy of Fallot because of the dynamic obstruction below the pulmonary valve. Tachycardia increases that, and they may have more cyanosis because now the obstruction is really faster happening and more strongly happening. We talked about finally the poor mixers, where it is not a matter of right to left shunt or decreased pulmonary blood flow. Actually, in transposition, there is increased pulmonary blood flow, yet they are still extremely blue because the circulation is not in succession like in the normal side, where it goes from the venous return to the right ventricle, to the lungs, to the left atrium, to the left ventricle, and then to the aorta and the body, and back to the right ventricle. Actually, it is in succession, where the blood flow or the venous return goes to the right ventricle, to the aorta, back to the right ventricle, to the aorta, and the lung or the pulmonary blood flow goes from the lungs to the left ventricle, to the lungs, to the left ventricle again, closed circuit, not mixing, and that's why they demand a mixing site, which is either the PDA or the ASD. Occasionally they will have a VSD, and the VSDs do not play a big role in the pathophysiology of transposition in the area that it really does not provide a good mixing site, unless it's a huge VSD, and that's not usually the case. The usual case is a small VSD just near the perimembranous area or the subpulmonic area. Actually not the subpulmonic, just in the perimembranous area, because if it is in the subpulmonic, then they are really different type of transposition, which is not the goal of this presentation and this explanation, because there are many types of transposition depending on VSD location, presence of pulmonary stenosis or not. We're not going to make it too complicated. We're just talking about the mainstream pathophysiology of cyanotic congenital heart disease. Thank you for your audience, and see you inshallah in the next part, which is talking about left to right shunts and their pathophysiology.